Alright, this presentation is on motivational interviewing, but for the subjective examination and education. I'm Nick Rainey, and I'm a physical therapist, and I enjoy treating people and trying to communicate well. So we'll have some fun with this one. It is a little bit different slant to motivational interviewing than what we often see. So the first thing I want to do is discuss what may need to change for these examples. We have 3 examples here: low back pain, knee OA, and someone that needs surgery. And these are people that may have altered beliefs. We're not going to go in depth on each of these examples. We are going to have a little role play at the end with low back pain. But what I want you to do now is think of an actual patient that came in recently that fits one of these categories. Somebody that either has low back pain, somebody that has knee OA, and maybe somebody that thinks that they shouldn't be doing as much, thinks that there's just wear and tear, thinks they should be laying off of it just because they have knee OA, and maybe somebody needs surgery but doesn't want surgery, or is putting it off when they should have it earlier. Sometimes we may be trying to get people not to have surgery who think they need it. But think of maybe a reason why you'd want to talk to somebody about why they would need surgery. If you haven't had anybody that fits recently for that, at least one of these you should have seen somebody for. So think of an actual patient with that. So motivational interviewing. It was developed by Miller and Rolnick not too long ago, within the past few decades. And it's a guide. It's guiding a style of communication that sits between following, just good listening. So we want to be good listeners, but we also need to be able to direct people. We don't want to just be authoritarian and just tell them what to do. And so it's really about good communication, but it's guiding that communication. So what is motivational interviewing? Let's go a little bit more in depth. And it helps people to explore and resolve their ambivalence about change. And this is where typically we talk about change as behavioral change. And that really is where motivational interviewing has been most used, and for very good reason. But we're going to talk about it a little bit differently today. We're going to get to some examples here in a minute. In motivational interviewing, this is where the topic can be quite dry. And so I want to make this relevant for your patients. I say it can be dry. It can be very interesting, but it can be dry if we get too much about technical terms. But basically, people need to have a reason to change and need to understand that they need to change. It's not just going to happen. It has to be collaborative. You can't force them to do it. People have agency. We can't try to take that away. So the spirit of motivational interviewing. Anytime you hear anybody talk about motivational interviewing, they'll talk about the spirit of it. And it's basically coming alongside them and accepting that they have agency and that we need to help them, but help them pull out what are their true motivations and then really be understanding. For instance, I had a lady yesterday. I was thinking about how can I utilize this to help her accomplish what she needs to do. And then I find out that her social determinants of health aren't being met. So basically, a lot of these, I need to have compassion, and I need to see that, maybe there's nothing I can do to help her do what she needs to do for her health because she's worried about other things. But if I would have just been directive and told her what she had to do, it wouldn't have gone as well. Now, it didn't go perfectly, to be honest. She's still not going to do some of the stuff that she needs to do. She has other stuff on her plate that she's worried about, that she's got to take care of. But I was very glad that I didn't, scold her or tell her what she had to do and that she was lazy or anything like that. The spirit of motivational interviewing is basically helping them understand what their motivations are, talking about it with them, not telling them what their motivations are, finding out what they are, coming alongside them. That is the spirit. And so principles, we need to make sure we express empathy. We need to find out where the discrepancies are. Sometimes they may think something, they may say something but really feel another thing, and they haven't been able to articulate. So the interviewing process, asking them questions, is to find out where they really lie with it. And if there's resistance to change, we don't just go up and fight it. We keep asking questions so we can find out what is the best route for them and help them identify what the best route for them is, and then figure out a plan together. You'll always hear about communication skills, call them the ORs. You ever hear about ORs in motivational interviewing? This is what they are: open-ended questions, affirmations, reflective listening, and summarizing. So we want to start with open-ended questions. We want to affirm of who they are as an individual, make sure that they know that they are valued, and the reflective listening and summarizing, those can be more close-ended questions. We want to make sure that we're on the same page as they are. You can get into a lot more details of how to utilize those skills. That is outside the scope of this presentation. I'm not looking to make you an expert motivational interviewer. It's to apply it a little bit differently than maybe what you have in the past. These are the stages of change. Some people have no idea they need to change. Some people know they need to change, but they're not quite sure they're ready to. And then then we have people that are working on changing or are making changes or have made changes. So what can motivational interviewing be used for? Behavioral change is the most common. So examples of this is stopping smoking, eating better, exercising more, doing a better job with sleep, stopping alcoholism, drug use, something along those lines. Typically those are your common behavior changes that this can be used for. But other ones are knowledge or understandings or beliefs, and aren't so much behavior change, but they influence behavior. So if you have a belief that you're imaging that of your knee away, that there's wear and tear, there's damage there, and so that you understand that, okay, I better stay off my knees so I don't keep making it worse. We know that that's not the best way to manage knee arthritis. Now maybe temporarily we need to, let it calm down, we need to get off of it, but long term that's not helpful. I mean, the American College of Rheumatology recommends exercise for arthritis is the number one thing that will help. So we don't want to, so the belief, people's beliefs and what they think needs to help does not line up with the evidence. And so those people are going to be in pre-contemplation stage, right? They don't understand, they have no idea that they need to change their belief. It's not so much a behavioral that influences behavior, but if I just go talk to them about behavior, I need to first back up and do motivational interviewing for the belief. And I may just be able to tell them. We don't have to use motivational in every communication in life. Sometimes we can just tell them, but sometimes we have to be able to work through it a little bit more. Belief about prognosis, if they think they're only going to get worse and that's not accurate, then we need to have a discussion. Now, some people just will get worse. There's some conditions that are very progressive. Some people view as progressive and may not be, like a knee OA. Sometimes that gets worse and sometimes it doesn't. Beliefs about effective activity. How many patients believe that if they exercise more, they do something, that they're just going to make themselves worse, that they could injure themselves. So we need to help educate them there. Maybe it's about surgery, whether they do or they don't need it. Understanding of pain. We got to help them understand. They think they understand pain, but most people don't understand pain science unless they've had formal education in it. Most healthcare practitioners don't understand the science of pain. And maybe they have an external locus of control. We want to move them more to an internal locus of control. So these are areas where motivational interviewing can be used for, but we typically don't think about it. We just want to authoritarian, direct them. This is what it is, but we don't guide them through that process. We don't help them see how that is. A common place that these things can be used for, in my view of it, is cognitive functional therapy, where they're teaching people while using function, functional activities to help teach and move people along the process with that, which I think can be very effective. What are signs you failed at motivational interviewing? These are things that we've all felt, or that we've all done, and if you haven't recognized those, then you're missing that. If they seek additional care that you didn't recommend, that means they think that they need something that you don't think. Now, sometimes they may have an idea that you don't. That should be elicited from them. If they're planning on going seeking other care, that means that they're not getting it from you. Now, maybe there's something that they can't get from you, but that should be discussed. Hey, this is where we're going. If I think somebody's going to get 90% better with me and they go seek additional care, they don't really believe that 90%. Or, they were told by somebody else to go there and you're just not closing that communication loop. So if they seek additional care you didn't recommend, and we all had this happen to us, and anytime that happens, I think, ooh, I missed a conversation there. I thought we were on the same page and we weren't. Or they're not following your advice. That may be seeking additional care, or maybe they didn't do an intervention or an exercise or some type of self-management strategy that you gave them. Maybe they're not coming to the clinic. Maybe they're missing appointments, and there could be good reasons for this. Not every time somebody misses does that mean you failed, and that maybe somebody got sick, they got in a car wreck, something like that. But if they're just not finding the value in it, then there's a disconnect. Remember, motivational interviewing is a partnership. You want to be moving along, their progress together. And if they're doing different things than what you thought they would do or than what you expected them to do, you're not on the same page. Generally, just not being on the same page as the patient is a failure in motivational interviewing. And these things happen. We want to be on the same page as people. Now, that doesn't mean that they do everything that we think. It's not that you're a failure if you recommended one thing and then they didn't do it. If you knew that they were going to go a different direction, then you're on the same page. Even if you may not agree with the page that they're on, you want to be on the same page as them. Remember, people have agency. We're in this process together. So let's go back to these examples. Low back pain, knee OA, someone that needs surgery. We're going to go into a role play now with somebody with low back pain that comes in. It could be a variety of settings, whether it be primary care, physical therapist, chiropractor. They're coming in with back pain, and now we're going to start finding out what's going on. We want to use these principles we've talked about with motivational interviewing. So the D's on this mean the doctor, the P's mean the patient. That way you can follow along.
Okay, so if you're saying yes to everything, can I get your lashes?
My lashes?
Yeah.
It looks like you're having low back pain. Is that what you're hoping I can help you with?
Do his
Yes, it's been terrible recently.
anterior shoulder here, and then some supraspinatus.
Can you stand and show me where? What do you think is going on with your back? I think I have a slip disc or arthritis. Sounds like this has been pretty painful. Yes, it's made it hard to work, put on shoes, do anything with my kids, play pickleball. Better get this figured out. That's really affecting your life. When does it bother you the most? I'll do my doctor voice. When does it bother you the most? When I'm on my feet too long, when I lift anything, when I brush my teeth, pretty much everything makes it hurt. Are there any positions or times of day you don't have back pain? Oh yeah, if I'm lying down or if I haven't been doing very much. So it sounds like there are times when you don't have pain, but much activity at all flares it up pretty quickly. Oh yeah. How long has this been going on? For a month. Is it getting worse or better? It got worse for a couple weeks, and now it's staying about the same. Do you think it'll go away on its own? I don't know. If it's a slip disc or arthritis, I assume it'll just keep getting worse. That may be true, but sometimes even if it's a disc, or if there's some arthritic changes, the pain can get better on its own. What do you think will help your back pain? I don't know. I assume I need an MRI so we know what's going on. That may be needed, but let me ask you a few more questions and do a little testing. Is this something you think you may need surgery for? Oh no, it's not that bad. Good. From what you've told me, I agree with you. Let's do a couple of tests. Then the doctor perform myotome testing, reflex testing, range of motion testing. Now they circle back around. The good news is that reflex and myotome testing indicate there's no neurological involvement. That, combined with the fact that you can find positions and times when you don't have pain, is really good news. Imaging is indicated if we want to consider surgery or injections. Both can be helpful for nerve pain or damage from the back, but luckily, that's not the case for you. Thus, I don't recommend any imaging at this time. What do you think about that? Don't we need to know what's going on? It would seem to make sense if you have an image. Would an image would show that if you have something wrong, an image would show what's wrong, so we know what we need to do. Is that what you're thinking? Yeah, that's often what people do think, but it's actually we've seen that's not the best path. What we find is that everyone's spine shows something, and it isn't helpful for treatment unless we need to consider surgery or injections. Do you think surgery or injections are needed? No, I just think an image would help us know what to do. What other treatments would you like to consider? I don't know, maybe a stretch, or maybe I need to see a chiropractor. So imaging won't indicate anything for conservative treatment. Something like, we've discussed, like what you mentioned, the stretching or seeing a chiropractor. That said, I'm totally on board with what you're thinking may be helpful. You're hoping that if you can get the right type of movement, you can feel better. Well, that's stuff that we can definitely help you with, whether it be exercise or some type of manipulation. Do you want to see if I can figure out what conservative treatment, like a stretch, exercise, movement, manipulation, etc., will get you out of this pain? So that's the role play. We're now going to go back over some of the initial slides to see if we were able to use this. So remember, it's guiding. It's a style of communication that sits between following, so just good listening, and directing. And so that's what the attempt of that role play was for. Wanted to listen to where they were at, and then give some direction. It wasn't exactly for behavioral change. I mean, the behavior, they thought they just need to go get imaging, but they're sitting in your office. Can we listen, hear what they're saying, and then guide? Remember, it's a communication style that helps people to explore and resolve their ambivalence about change. So initially, they don't have ambivalence. They don't know they need to change. They're in the pre-contemplation. But then during the contemplation, we move them somewhat quickly, and sometimes it may take a while, and sometimes it's not worth it. Sometimes it may be a lot of work to change that viewpoint, and we may not need to. Sometimes people just go get an image. But that's how the goal is to be able to do in that first encounter, go with the best path. And if not the best path is not that bad, maybe go with it. If they had a very, different path that could be dangerous, for instance, maybe they're suicidal with this, maybe then we really need to work that out with them and probably get them to somebody that's more capable than we are of working out that through with them. But we want to make sure, can we work them through that? But if it's not that bad, then maybe it's not worth all the effort. If at the end they really want an image, maybe say, fine, let's go get an image and let's talk about it, after you get it, what those imaging may mean. If they just want to jump right to surgery, it'd be a bigger deal we'd want to try to avoid. Obviously, it's suicidal. We need to do what we can and get them to the right person. So there's just a big gamut there. But we want to be there as a partner with them. Spirit of motivational interviewing, again, that partnership, except they have the right to choose. If they just insisted on imaging, we could honor that. Now, if insurance or, other factors at play, then, we could pass it off on those. But we want to be there with them. And we want to make sure that they have the reason, looking to evoke their motivation. So what's their motivation for getting imaging? And they want to know what's wrong, but that's not actually, they just have a lack of understanding. They're not looking for surgery or injection, so we're helping them see the discrepancies between where they, what they want and what they think the best pathway is for. They want conservative interventions, that person, but the best path isn't going for imaging. And so that's, but with the rolling, so with this, we express empathy, helping them see the discrepancy of what they want versus the path they think they need to go, and rolling with resistance. Don't just tell them they're wrong. Ask them more questions. Find out how we can help them get what their goals are. People have agency. We need to help them identify what they truly want and make sure we're a partner in them with getting that. Using open-ended questions, making sure to give them affirmations, and then also listening and summarizing so they know that we're on the same page. All good salesmanship, and salesmanship is often communication. We want to make sure they get to where they need to be. We need to, if we know where that is, we need to help guide them along, there. Now, if their goal is different, where we if their goal is different than our goal, we need to figure out so we can get common ground. We need to guide them so they can get where they want to be, and we need to sell them that this is the path. So we need to get them nodding. So with that, with the close-ended questions, with reflective listening or summarizing, we need to get them nodding yes. And then we look at the stages of change. Initially, this person's in pre-contemplation. They didn't have any idea that anything needed to change. It wasn't really behavioral change. It was a misunderstanding, lack of knowledge. So then we can walk them through that, and they start to see, okay, maybe I don't need. Okay, that's what we can go with this route for now. If they don't get better, then we would look at imaging, right? If people fail conservative care, then we need to look and see if maybe it's something that wasn't an emergent red flag, but is being missed, and we need to go with more invasive care. So we need to help them move throughout the stages of change, even though this is not this may not be behavioral changes. It's more understanding. So different than the classic role of motivational interviewing, but still it goes back to that initial slide. It's between just following and just directing. We're working